We're live.
Hello, everybody. Thank you so much for joining us, especially on what, at least here in mid-Missouri, is turning out to be a beautiful day. So we appreciate you taking the time to be here with us. I will start at the top. So my name is Dina Vanderzalm. I'm the healthcare organizer with Missouri Rural Crisis Center. Behind the scenes here, we also have Jamie Blair with MRCC, our rural organizer. She'll be helping me keep an eye on Q&A and chat. So if you have any questions, please feel free to go ahead and ask those throughout, and then we will have time a little at the end as well. We have, I believe, I hope, fingers crossed, a third-party transcription service for closed captioning. If you need that, look down at the bottom for that option. I will say with the caveat that it is AI. So if you see anything that looks like a goofy transcription, we'll go ahead and blame our new third-party captioning service and not our expert panelists. But without further ado, for those of you who are new here, MRCC, we're a statewide farm and rural organization. We work on many, many issues, but one of them has been Medicaid expansion for the last decade. And we are thrilled that we are where we are now on the brink of having implementation happen. And so we have brought together some excellent panelists to help us answer all of your tough questions. We have Brian Colby, who is Vice President of Public Policy at Missouri Budget Project, Sarah Lynn Irwin, who is a Marketplace and Medicaid Coordinator at the Northeast Missouri Health Council, and Sydney Watson, who is with the St. Louis University Center for Health Law Studies. And they together will be able to answer all of your questions. I'm not sure you could stump them if you try, but we welcome you in that attempt. And with that, I will turn it over to Brian Colby to get us started looking at where we stand with budget.
Hi, everybody. My name is Brian Colby, as Gina just said. And I'm going to talk a little bit about the budget. The Medicaid expansion obviously has a huge impact on the Missouri state budget and on the Missouri economy, and especially the monies that go to support our healthcare system. So go ahead and hit the first slide, Dina. So all told, Medicaid expansion is going to bring just shy of $2 billion into the state of Missouri and into Missouri's budget. A large chunk of that will go to taking care of the newly eligible, what we call the expansion group, the adult expansion group. Some of it will go to administration. Some of it will go to mental health services that are paid a little bit differently. But all told, it's about $1.9 billion. Of that is about $103 million of general revenue. Now, general revenue is the tax dollars that we collect from our sales and income tax. It is the money that we have some discretion over how we spend it. And we also think that this estimate is way too high. We don't think that there really will be a need for state dollars to go into Medicaid expansion. The vast majority will be federal dollars. So of that 1.9 billion, we think, or it's estimated by the state that 103 million will be general revenue dollars, state dollars. And then we have another funding mechanism, which is called our FRA, or a hospital provider tax. These are federal funds that are leveraged down to the state of Missouri to help pay for our Medicaid program. And there'll be more of those dollars available to help. The state is estimating somewhere between $50 and $129 million in new FRA federal funds. We think that's too low. We estimate on the low side, it's going to be closer to about $220 million of new federal dollars on top of the $1.8 billion in federal funds that will come and take care of our new expansion population. In the budget, they're calling it the Adult Expansion Group, AEG. It has its own separate line item, which is a little bit strange. Normally, it would be in a different line item, say for hospital cost or managed care costs, the insurance company that takes care of Medicaid recipients. But they have it in a separate line item. That line item is $1.5 billion and change. The rest of the money is spread around with administration costs and new services for the Department of Mental Health. Next place, please. So the really good news, and one of the areas in healthcare that really benefit the most from Medicaid expansion is mental health. Mental health treatment for those who may need it, either comprehensive mental health treatment or alcohol and drug rehabilitation services. Medicaid expansion will allow for $154 million in new funding to go to the Department of Mental Health. And it will also fund some new caseworkers, 6 new crisis mental health centers with about $15 million in new funding, and a few other elements, one of which being a behavioral health care home, which is an innovation which helps to coordinate healthcare for those receiving behavioral health or mental health and drug and alcohol treatment. So very good news for our mental health budget, as well as our Medicaid budget. Next slide, please. So one of the things that is necessary to have Medicaid expanded, even though we won the ballot initiative and it's in our Constitution, is that it has to have an appropriation. By law, the state has to appropriate the funds. And that may or may be a difficult thing to do through our legislature. As some of you may know, it was much less popular in the legislature than it was in the state as a whole. And they have structured the spending for Medicaid expansion a little bit differently, a little bit strangely. And so we're going to watch that space closely, because some folks have played with the idea of taking Medicaid expansion dollars out of the budget and frustrating this process of moving forward with implementing the expansion. Now, I don't have a crystal ball. I don't know what exactly they will do, but it's something that we're going to watch closely. One thing they will have to do is to tell the federal government that we are expanding Medicaid. And so they will send a special communication called a State Plan Amendment, or a SPA, to CMS, which is the federal partner agency that we work with, that will pay for the expansion. And we will tell them on March 1st that we're expanding. So whether or not we fund it, we'll be frustrated by the fact that we've told the federal government that it's part of our Medicaid program, and probably would bring a lawsuit if they did not include the funding. But we do believe at the end of the legislative year that the funding for Medicaid expansion will be in the budget. If not, we'll be back in touch with you all. Next slide, please. I just want to take a brief moment and then hand it off to my learned partners to thank you all at the Rural Crisis Center for all the work that you've done over the years to help on Medicaid expansion. It's been a long road. It's been a tough road. You all have been vital to getting the word out of how important it is to our rural areas and to our farm communities. And so I just want to take a brief moment and say thank you. Here's my contact information. Feel free to contact me after this with any questions you may have about Medicaid expansion of the budget. And at this point in time, I'll hand it over to the next panelist.
Hey, Brian, before you hand it off, we do have a couple of questions in the Q&A. Melinda Hemmelgarn would like to know, do we have a way to talk about Medicaid expansion in terms of how much it will save taxpayers? For example, how much to give mental health care versus incarceration?
Yeah, there's some line items in the budget that line this out. For mental health, we have savings to the normal mental health budget, somewhere in the area of about $50 million. $15 million of that will be general revenue. We're kind of turning around and plowing that back into the Department of Mental Health so we can expand the program out to be about $150 million more dollars to provide mental health services. But yeah, there are savings in our criminal justice system. There's savings in our hospital systems. There's savings all across the board. And for that information, we can kind of provide you a little more detail. The funny thing is this year, our department and our budget chairs are not including those savings like we had predicted they would. And we've seen the savings in other states, savings not only in the healthcare system, but in the criminal justice system, and new revenues that will come to the state. We expect to see about $37 million to $50 million in new income tax and state sales tax, because we're going to be spending, $1.9 billion of new federal dollars into the state. So there's a whole bunch of ways it benefits the state, not only by covering more people, but by more economic activity. And we can get you some information on that if you'd like.
Thanks, Brian.
Have any other questions for our budget expert? And if you don't have them now, you can we can circle back at the end. This is not your only opportunity. We can go ahead and move along here. So next up, we will hear from Sarah Lynn Irwin.
Good afternoon, everybody. I'm Sarah Lynn Irwin with the Northeast Missouri Health Council, located in the northeast part of the state. We're an FQHC. Going to go over a few points for Medicaid expansion today, things that we've just recently found out from FSD that we are able to share with you. So let's go to the next slide, please. So first of all, Missouri Medicaid expansion was approved by the voters in August of 2020. The expansion group will be called the Adult Expansion Group, as Brian mentioned, and applications for that group will be accepted beginning July 1. There will be no early applications accepted. So everything begins on July 1. Enrollees need to be a Missouri resident, age 19 to 64. Have income at or below, it works out 133% plus 5% disregard, which works out to be 138% of the federal poverty level. This includes healthy adults who don't currently have children and are currently excluded from the Medicaid programs. They can't be receiving Social Security income or SSI or Medicare Part A or B, because those groups are handled in the adult Medicaid that for disability, age blind, and disabled. They can't be eligible for under any of the current mandatory Medicaid groups, as in Health Net for Families, which are for parents and children. Can't be eligible under pregnant women, and can't be eligible for non-spin down, age blind, and disabled Medicaid. The adult eligibility group is income-based and does not count resources or assets like the adult disability group does. Households are based on tax filing households. So if whoever's in your household you claim as dependents and yourself, that's going to be who you put on the application as far as who's in your household. If a custodial parent is applying for Medicaid for the adult expansion group, they must also apply for their children if their children are not currently receiving Medicaid or any other type of insurance. Next slide, please. All the expansion group enrollees will be under the MAGI, or the Modified Adjusted Gross Income population, and they'll need to enroll in one of the 3 managed care plans and select a primary care provider. The 3 plans are listed there: United Healthcare, Healthy Blue, and Home State Health Plan. Just a little side note on that, Medicaid, if you're approved for the expansion group, you will automatically be assigned to one of these groups, one of these care plans, but you have up to 90 days to change to any plan that you would like to. And it's a simple process, and there's a link at the end of the slides that will give a link to a managed care enrollment guide, which explains those steps in easy to understand terms. A new streamlined application is being developed to replace the current application. So therefore, using the new streamlined app, enrollees will be able to apply for multiple programs on one application, where right now you apply for food stamps and Medicaid, childcare, etc. You'll be able to apply online through the customer portal, which is available 24/7. That's the requested method of applying, because it goes directly into the system. A lot of the other, with the exception of phone, a lot of the other ones have to be entered by the caseworker, so it takes a little bit longer to get that done. So where possible, suggest to individuals to apply online. There's the phone numbers to apply by phone. And basically that's the easiest way for a lot of people, because sometimes the forms will confuse them, because, and the phone application, it's somebody's asking the questions and they're giving the answers. So the streamlined web application and the paper application are not quite ready yet, but they will be ready before the July 1 start date. That's the one, if you've heard of the Sevilla project that has been working with FSD to create that new streamlined application. Applicants can request prior quarter coverage on their application, but it will not go back prior to July 1. So really prior quarter, say if you apply August 1st, for sometime in August, you can request prior quarter coverage for July only. And you have to meet, for prior quarter eligibility, you have to meet all of the requirements of eligibility for each month in which you want coverage. So you may request for 3 months, but if your income doesn't meet the guidelines, you may only get just 1 or 2 months of that, or you might get all 3, depending on if you're eligible. Those individuals who are approved for Medicaid will have 2 ID cards. This is one thing that we had some issues with when the state went statewide with managed care back in 2016, is people threw away their MoHealthNet card and only kept their managed care card. You need to keep the MoHealthNet card, because that's for pharmacy. So if they need medication, they'll have to show that ID. But if they go to the doctor, they'll need the managed care ID card. Next slide, please. On January 28th of this year, the MoHealthNet division released a public notice on their website that had the proposed state plan amendment, as Brian talked about. It was open for public comment between January 28th and February 15th, but you can still go to that link listed on the slide if you want to look at the state plan amendment. It looks like really it's going to be pretty straightforward, and none of the coverages are really changing for this new expansion group. I know the next point, FSD is working very hard on creating an implementation plan that's aimed to have a smooth rollout and creating as little confusion and frustration as possible. Kim Evans, who's the director of the Family Support Division, is very aware. She's come up through the ranks from a caseworker forward, and she really is working hard to make this go smoothly. So they really, I think all the department is really working to try to make that work good. While we don't know what that implementation plan will look like exactly yet, we can work on plans for what each of our organizations can do to get the information out to individuals on when, where, and how they can apply. For example, flyers, advertising, your workflow plans. So what you can do for those that are going to do enrollment within your organization. Those are some things we can work on now. It's still pretty early to do a lot of things, but you can get basic information out as to, like, hey, it's coming up July 1, be aware of this, come back and talk to us at that time. As with any new rollout, especially of this size, there's probably going to be some issues that arise, which could put a lot of stress on everybody. But the main thing that we need to remember is we're all working towards the same goal of getting people enrolled and getting them coverage. Keep a positive attitude and keep informed on what's going on, so that you can help those individuals that are trying to enroll and maybe reduce everybody's stress level a little bit. Iva Eggert-Shepard from the Missouri Primary Care Association has been working on a flyer with Missouri Foundations for Health and GMMB for clinics and facilities that can be personalized for each organization's needs. And FSD will be coming out with their own flyers within the next few months as well, explaining on how they're going to do that, who to contact. This is what IVA's flyer is going to look like. And like I said, it should be released soon. Actually, it came out just yesterday or the day before. So I'm not sure how they're going to release that. If anyone's interested, I'll just have to get back with Dina maybe and let y'all know. The last slide, next slide, please. FSD stands for the Family Support Division. They are the individuals that they determine the eligibility for Medicaid. So when you do an application, it goes to the Family Support Division, and they look to see if you meet all the eligibility guidelines, and then approve your case if you're eligible. So this slide here is helpful links. There's that MoHealthNet Managed Care Enrollment Guide. It is updated by MoHealthNet online, so if you use that, that's a good thing to bookmark on your computer, because they do keep that updated. It has the contact information for the 3 managed care plans, the number for the managed care enrollment helpline, which can help you enroll in a managed care plan if you're confused or need assistance, and instructions on how to change health plans or choose or change a primary care provider, and what type of benefits are covered. The Missouri Foundations for Health has a great publication called Missouri Medicaid Basics. It's great information out there. I encourage everybody to go out and look at that to become a little more knowledgeable about general information for Medicaid. And then the last one is the Family Support Division MoHealthNet Monthly Management Report. It contains several different tables with various information, such as Medicaid eligibility and SNAP food stamp numbers by region, county, and program. And then next slide, please. The last slide is from the case counter. The link is there at the top. This just updated and within the last day or so to show the January numbers. So it's just kind of some information that is helpful if you want to know how Medicaid breaks down a little bit. So there's that link, and that's all that I have.
All right, Sarah Lynn, real quick. It looks like Cindy would like to know if there will be a mobile app for applications.
You can, yes and no. They encourage people to apply on their phones if possible. So yes, it is available. It's going to be a lengthy application, and it's multiple pages. So it just depends on if you have limited minutes, but yes, you can apply through your phone.
Okay, thank you. And I would like to let everybody know that the slides will be available after the meeting. I've gotten several questions about it, so I just wanted to say it out loud so everybody got to hear.
Good. All right, so we will go ahead and see here now from Sydney Watson.
Am I on?
Yes.
Okay, if you'll go back to my first slide, thank you all for inviting me to be part of an MRCC event today. This is one of my favorite organizations. And I come to you while Sarah Lynn and others are working on the ground on enrollment, and Brian's working on budget. As a university researcher, those of us at SLU have joined together with a team from Washington University headed by Tim McBride, with generous support from the Missouri Foundation for Health, to figure out what we can learn from other states as we move into implementation. Sometimes it's good not to be first. We are 38th. So there are a lot of states who have gone ahead of us and a lot of good lessons to learn. And my theme is, let's do it. Let's implement. Let's go forward. So Dina, if you'll give me the next slide. In doing this work, the folks from Washington University and Tim are experts on numbers and calculating numbers, and that's the part they've been doing. And the question we haven't addressed yet is, how many new adults do we think are likely to enroll in Medicaid expansion in that first year after enrollment opens July 1, 2021. Washington University did an estimate that many of you will remember were numbers we used during the campaign to pass the ballot initiative. They updated those numbers, taking into account COVID as well as they could. And they are estimating, based upon what happened in other states, that about 250,000 new adults will enroll in Medicaid. More are eligible, and we'd like to welcome more in, but that's the likely number. There is also a number that the governor's office has come up with in their budget calculations. That number is 275,000 adults, and we think those numbers are very close and make us feel like our numbers were a great estimate. We also think that the governor's office is probably estimating some people who are already on Medicaid who are simply going to move around, but that's a number. The WashU folks are also estimating that because of Medicaid expansion, that we'll see about 50,000 children join Medicaid. As Sarah Lynn said, as parents apply for Medicaid, they will also be asked to apply for Medicaid for their children if their children aren't already enrolled. And we think that that will result in us finding 50,000 children who probably don't have insurance now who can be covered by Medicaid. All good news. The other thing that Tim and his group did were looking at who these people were likely to be. And you'll see in this pie chart that about 60% of the people who will be enrolling in Medicaid, the adults, are likely presently uninsured. Those are the people we went out in the campaign and wanted to find and wanted to make sure they had insurance. We also anticipate that about 30% of the people who are covered are going to move from marketplace plans into Medicaid coverage. And those are people who earn between 100% and 138% of the federal poverty line. They can now purchase plans through the marketplace. They can get premium subsidies. They're getting good deals in the marketplace. But when we expand Medicaid, they will no longer be eligible for those subsidies because they will be newly eligible for Medicaid and have the opportunity to move over. And we want to make sure that all of those folks move over. And that's what Tim has anticipated. And that's why you see a 30%. We also think there will be about 10% of people who now have employer-sponsored insurance who will pick up Medicaid because you can have both coverage. You're not excluded from Medicaid expansion because you have employer coverage. For some people, Medicaid will be a better deal. For other people, they may want to have both coverage. And so, Dina, if you'll take me to the next slide, I'll tell you a little more about what the researchers at WashU came up with in terms of thinking about who are these folks likely to be. In terms of age, about half of them are going to be under 35 years old. They're going to be young folks. So those young folks that Cindy asked about who likely want to use a mobile app to apply or social media to find out. About 20% are close to retirement between age 55 and 64. In terms of the kind of family they're in, about 2/3 are not parents. And that's probably because now people who are single adults without children, it's almost impossible to qualify for Medicaid without expansion. In terms of the income level, about a half will be over about 75% of poverty. About a quarter will have very, very low incomes below 25% of poverty. But most are going to be working, either full or part-time, typically in low-wage jobs like fast food, home health, retail. That's been true for many, many years with Medicaid. We believe it will still be true even with the layoffs we've seen related to COVID. And many of those who are not working are those younger folks under 35 who are likely to be college students, community college students, or older folks taking care of children, or families with people with disabilities or seniors who need care. About 8 out of 10 are going to be white Missourians, and about 20% are going to be people of color. And Actually, Medicaid expansion, the people who qualify, we expect that there will be more white folks than there are on Medicaid now. And that's probably because we see people coming in at a slightly higher income, and because of historic wage discrimination and job discrimination, the racial balance changes. And since this is a program from Missouri Rural Crisis Center, this last bullet point is really important. About 40% of people qualifying, getting enrolled, are going to come from rural communities. About 60% are urban. And our population is about 30% rural, 70% urban in Missouri. And this is something that one of our people in our chat said earlier. Really, in terms of the percentage of people eligible for Medicaid expansion, it really helps rural Missouri. It's a boon for Missouri. And Dina, my next slide is a map. It's a map that's available online, and you'll get these slides, and we'll also put, if we can, in the chat, this link so you can play with this interactive heat map yourself. It shows enrollment by 12 regions across the state. The darker the region, the higher the proportion of the population that is likely to enroll in Medicaid expansion. It ranges from that light blue area, which is the St. Louis region, where it's 3.6% of the population, up to 8.5% in that south central region. But you can see very clearly from looking at this heat map that these darker regions are primarily rural areas. I encourage you to play with the heat map. You can go to these regions, you can put a clicker on them, you can see both the percentage of the population and the number of people likely to enroll. And if you hit on that, you'll see in the boot heel, we're likely to see 12,500 people get coverage. In South Central, about 8,000 people get coverage. Up in that North Central region, it's 6.6%, and I forgot to write down the number of people who will be eligible. But we're also going to hope to give you some information by county, so you'll be able to see exactly how Medicaid expansion is going to impact your community. So Dina, these are all the, if you'll take me to the next slide, those are all the numbers that our colleagues at WashU have been trying to learn about from looking at other states and looking at Missouri. What we at St. Louis University have been done is talking to people in other states, reading about what's happened in other states to learn their experiences. So I wanted to tell you a little bit about what we learned about outreach and enrollment, because all these numbers are based upon who should enroll based upon experiences in other states. But I have to say, other states have also hit hiccups. Nebraska is behind, and they think they're behind because there's been limited outreach because of COVID, limited discussion. Maine had some serious hiccups, particularly in getting the word out to rural folks and in rural communities. And Utah has had some challenges because of an ongoing political controversy there. So we can't think that because we passed a ballot initiative, they will come. Sarah Lynn has talked about the work the state is doing to get the word out, but there's a lot here for all of us to do. And what we've learned from other states is that we need both broad campaigns, but targeted outreach. You can go to the next one. That's a guy from Maine. I keep wanting to go canoeing. So broad-based campaigns are important. We're going to need to get the word out everywhere before we hit that July 1 startup date. But it's also got to be targeted. Social media works great for those young people, but for folks like me who aren't on Twitter and don't play around on Facebook, we need alternative ways to, for the hoopla to reach them. And I'll talk about some ways that worked. What's important is to have local partners who know their communities and who are trusted messengers in their community. And we know for many communities, those are providers, the community health centers, the behavioral health clinics, our local churches, our local food banks, and we need to engage all of their folks. The one-on-one enrollment assistance that Sarah Lynn and other folks provide is absolutely key. There are many people who don't have access to broadband for whom this is confusing, who are going to need help. And we also know there are challenges in reaching rural people, but we also have some great ideas on how to get it done. The problems, I have a feeling you all know well enough: a lack of broadband, a lack of computers, limited cell phone coverage. Particularly, we can't rely on that technology to work. But we also know that there are some great ideas in Kentucky. They used pop-up enrollment assistance at regional malls because they know that everybody goes to the mall, or at least used to before we had COVID. Also in Kentucky and Virginia, they stressed the ability to mail in paper applications because for many people, that was the easiest way to do it. And in Kentucky, they also learned that the best messengers was a local messenger, and an article in the local newspaper that had a story about a neighbor who had gotten coverage and what it meant to them. The other thing that Maine learned in particular was that educating rural people about what Medicaid is and what health coverage means is really important. A lot of those 60% of people who are uninsured have been uninsured for a very long time. And while COVID reminds us about the importance of health insurance, there are a lot of folks who are busy and have other things on their minds, and it's time to begin those conversations. And Dina, if you go to my next slide, it kind of repeats some of this, but it's the messages we've learned that works. Messages have to be tailored and targeted to particular communities. And we really need to talk about both why health insurance is important and why Medicaid's a good deal. We need tailored messages to fit local communities. In Kentucky, they're doing an ad campaign right now that's designed for seven counties which have a high percentage of uninsured Black Kentuckians. And it's an ad campaign around Black Lives Matters and end structural racism. It's a really powerful ad campaign for that community. But it's an ad campaign that they say not going to work in Appalachia. In those counties, they need a different message, and they do have different messages. We also know that we need those local partners to tell us what messages work in different communities, and we need those personal stories. And Dina, if you'll take me to my next slide, I want to talk a little bit about what we learned about tailoring messages about why insurance is important and why Medicaid is work. 3 questions people ask: am I likely to be eligible? What does it cover? What does it cost? Next slide, Dina. So am I eligible? Here's a slide from Virginia. They use this as a flyer. They use it as a wallet card. They use it on the web. And it's a really quick, if you make less than this, you're likely to be eligible. It also has, but I couldn't put it all on the slide, some frequently asked questions. What if I lost my job and I made a whole lot of money last month, but I'm making nothing this month? It's this month's income that counts. They also have other frequently asked questions about what if I'm an immigrant? And remember, assets don't count. But part of the materials you're going to see as the campaign starts is to get these numbers out there so people can really see. If I'm a family of 4 and I'm making $30,000 a year, yeah, you're likely to be eligible for Medicaid expansion. The parents are. And we need to start talking those numbers. The next slide addresses this question of, so what does it cover? Here's what Maine uses. Both free Maine Care and low-cost CHIP offer the same health benefits. They include nearly all health services, doctor's visits, hospital care, prescription drugs, physical therapy, mental health services, transportation. And in Missouri, we could add dental coverage, really important to people. Lots of states have a list that lists this out. But a lot of people don't have experience with Medicaid, don't have experience with health insurance. So talking about this is really good coverage. It is important to begin that conversation. And the final question and my final slide, Dina, is so what's it gonna cost me? Remember, in Medicaid, there's no premium for expansion adults, no deductible. They're likely to be the same copays for regular Medicaid, but compared to a lot of coverage, those are small copays. The message that Kentucky, that Maine, that Virginia, Montana all use is it's no cost or low cost. And the ad campaign that Kentucky's got going on right now, which I dance to, is 1, 2, 3, no cost to me. And I'm working on the jingle to go with it. And I think Brian's going to provide the drum beat for that. But as we move forward, this is a conversation we're going to all get to have and think about how best to have it in our communities. In Kentucky, that's the gentleman who's the poster child for certain counties, but they also have a poster that has an Hispanic family on it, one that has an older woman on it, one that has a mom with kids. I want to thank all the people who are doing all this research. We're having a great deal of fun finding out good lessons for other states. And we are going to be looking into more about making sure that there are plenty of dentists and clinics and primary care and mental health providers available, and look forward to sharing a lot more information with you. So thank you. So my slides are done, Dina.
All right. Thank you, Sydney. We do have a question for you. Melinda wanted to know, would abortion services be covered? And I think I was able to answer that because the Hyde Amendment prevents that. Is that correct?
Yeah, abortion doesn't change. It is the same coverage. It is now. I think there was another part of her question.
Yes, she did have a follow-up question about women's health services in general. What will be covered? Breast cancer screenings, birth controls, etc.
So the Women's Health Coverage Program covers people up to, I believe it's about 185% of poverty. That is over the level for Medicaid expansion. Women who are in that program now, where the only coverage they get is family planning services, will be moved over, should be moved over into Medicaid expansion, where they will start getting this full package of coverage. And the state is working on that process, and people like Sarah Lynn are working to make sure we get all of those people moved over. Coverage for the breast and cervical cancer screening will work the same way. We want to get those women into Medicaid expansion, the ones who fit within those monthly income guidelines, and keep coverage there. Same thing will happen for pregnant women who used to lose their coverage after 60 days. We'll be able to keep many of those women in Medicaid expansion.
All right, fantastic. Thank you for that. And we do have, Nancy's had her hand up for a while, so I think she's got something that she wants to add. If everybody's all right with that, I'll go ahead and unmute her. Nancy, go ahead.
Hello, yes, I just wanted to thank all of the panelists. What a fantastic lineup. I don't know how many people are on this webinar, but I do want to offer Cover Missouri as a resource. I put in the chat that those flyers Sarah Lynn was talking about will be going out maybe as we speak before this even ends. If you are not a Cover Missouri member, please contact me and I will get you hooked up for that. And those are also things that can be forwarded on and used, and much more to come.
Okay, thank you, Nancy. And we also have a question for all of the panelists. Where are the providers going to come from? There's a shortage now.
I will say to you that what we have heard from the other expansion states we have talked to is while there was great anxiety that there would not be enough providers, that people were able to make appointments, whether it was primary care, mental health, substance use treatment. There have been some challenges with dentists because we have an overall shortage of dentists. Spotty problems where we know we have some counties now where we don't have providers and dealing with that. But what we've heard over and over was that states worked with their managed care companies to make sure to creatively create networks, including using things like telehealth. And I think what's going to be crucial in the next few months is that we as community members also learn how to hold our managed care companies accountable to make sure that we figure out how to have providers. But I just have to say, the words people used with us was a game changer. You cannot imagine how this is going to change the world for you. And we also saw in Louisiana and Virginia an increase in nurse practitioners and physician assistants practicing across the state. I can't say we'll definitely see that here, but there was a cause and effect pattern.
And I will mention that there is some new money in the budget back from the CARES Act, which is some of the COVID relief money, and then some new money in the state budget for broadband expansion to rural areas, which will significantly help folks access telemedicine. And there's some legislation that will make it easier for folks to practice telemedicine. It's been a real game changer with COVID. And once we get the infrastructure set up, I think it's going to be a regular part of our healthcare system and be beneficial to rural areas.
And it's also kind of a response to the question I saw in the chat, do you have to be uninsured? You don't. But these numbers are so dramatic that we have this large number of people who are uninsured, who are suddenly going to have the opportunity to have Medicaid coverage, which also means that they will be paying their providers when they see it. And these are people who have either been going without or waiting till things got so drastic that they went to the emergency room or were being treated at a community health center, which treats people without health insurance, who will now be able to collect some money from Medicaid for those services. And that means they'll have more capacity and be able to expand their provider network.
And I'll just add one more thing. The benefit to having people with insurance, there are more payers, so there's less of a wait time in some of those community clinics. They're able to kind of slot people a little bit quicker and reduce wait times. And so as Sydney said, I think we're going to find a lot more access because we have more people with the ability to pay. And that will make a huge difference to providers.
Okay, it looks like we've got a couple more questions. Kathy would like someone to please clarify why fewer people of color will be eligible.
It's not fewer people of color, but the percentage breakdown between those who are newly eligible. The percentage of white is about 80%. People of color is 20%. Among present adults eligible and enrolled in Medicaid, it's about 70-30. My guess, my speculation is that right now, as an adult, to qualify for Medicaid, you have to be a parent and you have to be very, very low income, under 24% of poverty. And given historic discrimination, historic job discrimination, problems with our educational system, those very low income Missourians are disproportionately people of color. And I think as we bring people into Medicaid expansion who are earning around the poverty level, who are earning a little over that racial breakdown changes a little. So you see more more white Missourians.
Okay, and Charles would like to know, doesn't Missouri Medicaid currently only cover limited dental benefits for adults who are not pregnant or blind?
Yes, there are limits on the coverage. It doesn't cover everything, but it is dental coverage. And I will say my employer-sponsored dental coverage certainly doesn't cover everything. Somehow it just doesn't seem to cover much of anything, but it is some coverage, and some coverage helps.
Yeah, it will cover like extractions and fillings, x-rays. It will not cover dentures or partials. So, I mean, they can, you know, get those fillings, the cleanings and that type of stuff now under the limited plan for dental.
I would like to clarify on that. That'll be under the new coverage. Currently, they don't
Correct.
have any coverage unless they're pregnant or blind. Is that right? Yeah, that's what I thought. Okay, thank you.
No, there is dental coverage for
There is?
adults. Yes,
Mhm.
yes. Yes, and there may be confusion about that for a while. The legislature took that away, and then through the great work of the Oral Health Coalition, that was reinstated by the legislature a few years ago.
Oh, okay. All
Yes,
right.
and that's very important to know, because during that period of time, it is, you know, limited coverage, but when we did not have it, we saw a spike in emergency room use where people had untreated dental problems that turned into very, very severe physical conditions and ended up in the emergency room needing treatment. When we reinstated those dental benefits, we saw that emergency room use drop as people were able to get dental care.
All right.
One thing to note on that is sometimes with the adult dental, there is some minor copays. They're not excessive, but there is some. So it's not totally free, depending on the service that you get. I mean, we're talking like $5, $10. Okay.
And then it looks like we have one last question from Angela, who would like to know, will there be a penalty if a person does not want to do telehealth and prefers an office visit? And will there be limited visits for AEG population?
The first part of that is the visits will be the same. There won't be limits on it. I don't know that there's been any conversation about forcing people to use telehealth. I think it's been more that telehealth has been so limited, and we've seen increased possibilities during COVID-19. So it's thinking about how to increase choice. I will say one of the interesting things is the biggest uptick in telehealth has been in urban areas rather than rural areas. And that may have to do with broadband access or comfort with technology. So we're all on a learning curve about telehealth. I think it's a really important question because we want to figure out a way to use it that is comfortable for patients and is their choice.
Absolutely. All right. Well, if that is everybody's questions, I want to be respectful of time. We're actually going to end a few minutes early, which is amazing. Thank you so much to all of our panelists, Brian, Sarah Lynn, and Sydney. Your wealth of knowledge is so appreciated. And thanks for spending time with us this afternoon and sharing it. We've been recording this webinar so we can send around that to folks, and we'll have the slides. I'll save them as a PDF and make those available as well. So I know there was a lot of really great content and those links on there that folks need to access. So thank you so much to everybody for joining us, and go enjoy the sunshine for the rest of the afternoon.
Thanks, everybody.